My name is Professor Ken McDonald. I'm a consultant cardiologist at St Vincent's Hospital here in Dublin, and I'm also the Medical Director of the Heartbeat Trust. First of all, I'd like to welcome you all for tuning in here tonight. This, just to bring everyone up to date, is the first webinar that we've held from the Heartbeat Trust, so hopefully we'll not have any technical glitches here this evening, and hopefully you'll all find this of interest. I'm going to start off by talking to you about the background project that has been very central to the efforts of the Heartbeat Trust over the last 10 years. And then my discussion will be followed by a presentation by Dr Mark Wilkinson, one of the registrars in our unit, who's going to talk to you in a little bit more detail about how the heart works and about a little bit about heart failure. So, as I said, I'm going to start off by talking a little bit about the STOPHF project, which has been a project which has been central to the work of the Heartbeat Trust. It's been an effort to try and prevent the condition of heart failure, and I'll talk a little bit more, as Mark will, about heart failure throughout the rest of this transmission. But first of all, I'd like to tell you a little bit about the Heartbeat Trust, which has been the organisation which has been driving a lot of this effort over the years. The Heartbeat Trust is a heart charity, not to be mixed up with other heart charities in the country, such as the Irish Heart Foundation or CRE. We are a charity totally dedicated to the area of heart failure, again the subject of the presentations here tonight. We're a charity based here in Dún Laoghaire in South Dublin, totally devoted to trying to develop effective methods for the management and treatment of heart failure, not only here in the East Coast but also throughout the country. One of the central tasks that we've had in that brief has been trying to prevent heart failure. And we've been doing that in the context of trying to predict the people most at risk for heart failure, and within those people who we predict to be at highest risk, do our best to try and prevent the condition from occurring over time. And we do this therefore under the banner of what we refer to as the 3 Ps of predicting most effectively, protecting and then preventing heart failure. A little bit now about heart failure, and I know the term can be a little bit off-putting, especially for people who have the condition, but it's a condition that's been around for 300 years, and we've decided not to change the name of the condition because that in itself would cause difficulties. The condition, as I say, the treatment has improved dramatically, and probably the major concern we have with heart failure at present is the prevalence of the condition, the number of people in Ireland who have heart failure. It amounts to probably somewhere in the region of 2% of the population, which adds up to about 80 to 100,000 people, or indeed about 15 million people Europe-wide. What's probably more concerning is that over the next 15 years we anticipate that this figure will climb by about 50% to quite staggering numbers of somewhere in the region of 200,000 people in this country likely will have heart failure at that stage. And this increase will occur as a result of several factors, including the factor that we're all getting older, and it is a condition that we're more likely to get as we hit the middle and later years of life, but also because we're still not particularly effective at managing some of the risk factors for heart failure, such as high blood pressure. And then in addition, we have real healthcare problems with the emerging epidemic of diabetes, which is driving much of the problem that we see with heart failure. So with the present number of approximately 100,000, with the likely increase to about 200,000, and with a staggering number of people at risk for heart failure of the order of about 800,000, we do need to set about an effective way of preventing this condition. And that, as I said at the introduction, is one of the reasons why the Heartbeat Trust is in existence. It's to do its best to prevent heart failure. Now, in modern day cardiology, how do we predict people who are at risk for heart failure? Well, we have effective clues, but I would believe not as effective as we need. We know from looking and talking to people that those individuals with high blood pressure, diabetes, or other heart risk factors such as family history, cigarette smoking, and indeed recently, increasingly, those who've received medicines for other conditions which could be harmful to the heart, and in some cases they are people who received certain therapies for cancer. Those individuals are the group that are at risk for heart failure. But unfortunately, when you add up that number in this country, you come to that figure of about 800,000 to 1 million people. And it's just physically impossible to try and prevent a condition when it involves that number of people at risk. So we need to be a little bit more effective in defining risk than simply relying on the indicators of high blood pressure, diabetes, exposure to previous medications that may have harmed the heart. And we need to be able to take those individuals at risk in Ireland, maybe about 1 million people, those at risk in Europe, about 150 million people, and try and narrow that number down to the group that are at highest risk, so we can focus our healthcare resources on those individuals that try to be more effective in preventing heart failure. And again, that has been the task that the Heartbeat Trust has set about here in Dún Laoghaire and in the east coast of the country over the last 10 to 12 years. Now, the great advance that's enabled us to do this is the development of a blood test over the last 20 years, but still very much under the radar in heart medicine, and that's called natriuretic peptide. It's often abbreviated as NP or BNP or NT-proBNP. And this is a blood test that tells us an awful lot about the heart, about the health of one's heart. And the best analogy I can give in terms of working through why this is important is that it tells us who among patients with high blood pressure and diabetes are actually developing heart disease. Because the vast majority or a significant number of people with high blood pressure and with diabetes never develop heart disease, but we need to be aware of those who have those conditions who are actually developing cardiovascular or heart disease. And that's where this blood test comes in handy, because the development or the increase in level of this protein in the blood, this NP blood test, tells us that the individual with these conditions is developing heart disease, and therefore helps us be more accurate in predicting those who are truly at risk. And interestingly, it doesn't only tell us who are at risk for heart failure, but also tells us who would be at risk for other heart conditions such as stroke, heart attack, and heart rhythm irregularities. So this has been the central development that's helped us in the Heartbeat Trust develop a strategy to prevent heart failure and other cardiovascular conditions. So what we did in the STOPHF project is that we took people with those risk factors that I discussed a few minutes ago, high blood pressure, diabetes. Along with the general practitioners, we measured natriuretic peptide, the BNP blood test, in that group. And in those in whom the blood test was high, we brought a three-pronged approach into care. We ensured that the patient was well aware of what he or she should do with lifestyle modification to try and help their risk and reduce their risk. The GP took very good care of the rest of the heart health issues and other risk factors, and the cardiologist took care of ensuring that the best heart protective medicine was applied to that patient. And in doing that over a 4-year period, this project showed that we could reduce the development of not only heart failure but other heart conditions by the order of about 40%, significantly reducing the number of people who would otherwise have developed heart problems requiring hospitalization. So a very significant development, and for the first time internationally, this effort on this island has shown that we could prevent heart failure using this blood test as a guide. The international recognition for this effort has been substantial and does reaffirm to everyone the need for us to roll this out nationally. Soon after we published this work, the Royal College of General Practitioners in the UK gave this the award of the most important heart development for community care of heart disease in 2014. Subsequent to that, our Canadian colleagues altered the cardiovascular guidelines for that country, noting this particular development and suggesting that this should be standard of care. But most importantly, from our viewpoint, the two largest cardiovascular professional bodies internationally, the American Heart Association and the American College of Cardiology, recently approved this approach as the routine approach for heart failure prevention internationally, and strongly advocated that this should be routine care. So that has been a very notable advance, copper fasting and underlining the benefit of this approach. So what turned out, or what started as a research project, and some of you listening this evening may have been involved in that research project, has now turned into a routine clinical service here on the East Coast. And that's been a very important development, and I said not only that, it's received international recognition in terms of a standard approach to heart failure prevention and general heart disease prevention. We have now done our best through the Heartbeat Trust to expand this service beyond the footprint of the initial work, which was along the East Coast. We have now moved into the Midlands, where, along with some assistance from the Health Service Executive, we're now using this as a routine care in the diabetic population as a pilot study in the Midlands, and hope to extend it into the Carlow-Kilkenny area to try and again spread this process nationally within the country. What would be the impact if this was available nationally throughout Ireland from tomorrow? Well, the impact would be staggering. It would be able to prevent a significant number of cardiovascular or heart-related admissions through our emergency room year on year. And to appreciate the impact, I think many of us are well aware of the ongoing controversy regarding trolleys in the emergency rooms of our hospitals. If this approach of the STOPHF process of care was available nationally, we'd be saving 100 trolleys a day in our hospital system. And given that we have a national problem of about 500 trolleys a day in our emergency rooms, this would provide a solution for approximately 20% of that problem in a very straightforward process. So it would be a very impactful thing for us to be doing nationally to try and help one of our major healthcare problems. And why does it work? Well, it works because of three major components. One is the patient, secondly is the general practitioner, and thirdly is the specialist. There's no particular order to that, but it is important to emphasize the central role of the patient, because one of the important strategies that we have evolved with this is to try and empower the patient with increasing knowledge on their heart health, and also tactics and strategies to try and reduce risk over time. We've been able to liaise very closely with the general practitioner and making sure that what we do fits into the general health care of the patient, and this has been very important. And then the specialist help has been obviously to focus in on what would be best for the heart to try and protect against the evolving strain and reduce the risk for the patient. So this has been a very important three-pronged approach to healthcare. So where does this service go? And I think this is a very important and last component of this presentation, is to give you some insight into where this research project, which is now a service in the area, will go with the help hopefully of the HSE, but also of people such as yourselves strongly advocating for its use. Well, we believe over the next while that we need to become even better with our 3P banner. We need to become better at predicting people. So the BNP blood test is very useful, but we believe from some of the allied research that the Heartbeat Trust is supporting in UCD and in Queen's University in Belfast and internationally, that we will have blood tests which will help BNP become more accurate. We need to be able to develop better methods at protecting the patient, and thereby also better methods at preventing. So working on these three areas, we've shown some further progress over the last few years, and we know now that there are blood tests similar to but different from natriuretic peptide, which allows predict the patient who is at risk more accurately than just BNP. So this will allow us to be even more focused in looking at the true at-risk population. So this will be something that we hope to develop and evolve even further over the weeks and months and years ahead. Secondly, we're looking at new strategies to care for people who are at risk, and we're looking at new drugs which have just come on the market, which may be even better than the drugs we have. And again, I'd like to thank anyone listening who's involved in the Parable project, because this has been a very important, internationally first of type project looking at a new drug which may be particularly effective for this at-risk population. And this again has been done through the support of the Heartbeat Trust here in this region. And finally, we're trying to deliver on better methods of liaising with the patients and liaising with the general practitioners, because a lot of this does not require patient travel to a clinic, as much of our healthcare still does, but can be done through effective use of telecommunications and modern IT. And we've developed a method of communicating with patients and with their general practitioners called virtual consultation, where we can listen to and take the information from the general practitioner or the patient and give good sound advice, but not need the patient to travel to busy clinics and busy hospitals and with the hassle of getting into cars and on the roads and finding car park. And this strategy is shown to be very effective at providing effective community care, but still have the benefit of specialist opinion. So over the last 10-15 years, we've made very good strides in trying to develop and prevent heart failure. We have shown how a research project can now become standard of care and has been advocated as such in many international countries. And we hope to move and develop this nationally as our next goal. We have about 3,000 patients involved with the service, but one of the major challenges will be to try and persuade the policymakers in healthcare in this country to strongly support this service nationally for the impact that I've already outlined. I'd like to thank you for your attention, and now I'd like to hand over to Mark Wilkinson, who will talk to you a little bit more about the basic function of the heart and give you a little bit more detail about heart failure. Thank you.
So good evening, ladies and gentlemen. It's a pleasure to have this opportunity to talk to you. As Professor McDonald explained, I want to talk a little bit about how the heart works, the issues that can occur with the heart that lead to the development of a condition we call heart failure, and perhaps even more importantly, what we can do to try and prevent that. One thing I want to do first of all is dispel a few of the common misconceptions about the heart, which this is just for a bit of fun, but this is the sort of thing I often ask an audience when doing a talk, and it's interesting to see how many misconceptions there are. So the first one relates to the size of the heart. Now, because of the limitation of the way we're doing this evening, I can't hear your response, but if you take my word for it, usually when we ask people this, about 50% will get the size of the heart correct, and the other 50% will grossly overestimate how big it is. So you often get people who think the heart occupies almost the entire chest cavity. In actual fact, the heart is about the size of a human fist, and actually more accurately, if you clench your two hands together, you get an even better sense of the width, the height, and also the depth of the heart. It's actually a pretty compact organ, and given what it does, it's pretty remarkable it does it for the size that it is. Another common misconception, even more common misconception about the heart, is where it is in the body. If you ask this question of people, they will almost always pick box 6 as the location of the heart. There's a tendency to feel that it's out on the left side of the chest cavity. In actual fact, the heart is right in the centre. Now, because of the shape of the heart and because of the way it lies in the chest cavity, there's a little tendency for it to edge slightly to the left, but the bulk of the heart is very much in the centre of the chest cavity. The heart's a truly remarkable organ, and I'm just to exemplify that, I'm going to show you a few numbers. So if we were to look at the number of heartbeats that occur in one day, if we assume that someone's heart beats, for example, 80 times per minute, which would be a pretty normal number of beats per minute, and given that there are 60 minutes in 1 hour and 24 hours in a day, we end up having 115,000 or just over 115,000 beats in one day. And again, if you ask people this, they will guess in the thousands, but usually not as high as 115,000. If we then look at someone who's, say, 80 years of age, and given that they have 115 or just over 115,000 beats in a day, you end up with, at the age of 80, having a heart that is beaten 3.3 billion times. It's an extraordinary number. And as a human civilization, we've created some great engineering, but there's very little that can compare with the efficiency of the heart. And for the majority of people, most of the time, it does this without ever having a rest. It's an extraordinary organ. This is why we do what we do. The heart, in terms of its function, well, we can look at it as cardiologists in very different ways, but primarily it's there as a pump. And this is what everyone knows about the heart, that it's this very, very important pump. If we got a little more technical, we would describe it as really being two pumps, a left and a right pump. But for the sake of simplicity and for the sake of what I want to describe tonight, we'll think of it as just one simple pump. And again, if we had engineering friends here, they would tell us that it's the type of pump that we would call an intermittent pump. And that would be different to a continuous pump. So if you turn your tap on at home, you know that the water just keeps flowing continuously. There's no stopping and starting and stopping and starting. The heart, therefore, is an intermittent pump. It stops and it starts in terms of creating flow of blood. And we can make a great analogy with a foot pump. So as you know, with a foot pump, in order for that to work, someone has to press their foot on the foot pump, to press the lever down, to drive the flow of air out of the foot pump and into the car tyre. But just as importantly as that, it's necessary for the pump to relax again, to come up and fill with air so that it's primed for the next squeezing action. And those two aspects of an intermittent pump are really important. So there's the action of pressing down and there's the action of releasing to fill up again. If anything were to go wrong with either one of those things, the foot pump, the mechanism, the action of the foot pump will be compromised. So for example, you could imagine someone who comes along to use a foot pump whose leg is a little weaker, maybe they're feeling tired and they don't push it down enough, maybe they only push it halfway down. You intuitively guess that would affect the overall efficiency of the way the foot pump would then operate. Similarly, you could push the foot pump down normally, but there could be an issue with the way in which the foot pump comes up to fill for the next round. Perhaps there's some rust in the foot pump. And again, even though you're pushing it down well, you can imagine that if it's not relaxing properly, if there's trouble with the foot pump coming back up to fill up, that's also going to compromise the efficiency of the foot pump. And exactly the same thing happens with the heart. Two broad categories of issue can happen with the way in which the heart pumps. So on the one hand, the heart might not squeeze very well, and on the other hand, the heart might not relax very well. And when this takes place, it can cause problems in the body. It can cause people to start experiencing symptoms. And we call this combination of issues with either the squeeze or the relaxation of the heart, coupled with difficulties that a person experiences, symptoms, we call this condition heart failure. And as Professor McDonald suggested in his talk, it's an old-fashioned name. We still use it for very sensible reasons so that we're all on the same page, but we don't really like to emphasize that word. And part of the reason for that is that we're in a great day and age now where we can treat this condition very effectively. But if we're looking to see if someone has heart failure, or even to see if they have early signs of changes, we need a way of looking inside of the heart. And the best way to look inside of something is to cut it open. So I'll show you. There we go. So the best way to look inside the heart is to cut it open. And if we cut open an apple, for example, if we just slice it down the middle, we can see exactly what's going on inside. Now, we wouldn't be as cruel and unusual as to do that to an actual person, but we can actually slice the heart in a sort of invisible way. We can do it by using sound waves. And I'll explain a little bit about how this works, because patients often ask this when we scan their heart, how is this working? It's a very interesting technology. It basically uses sound waves. So we send sound waves out, and you can imagine if you were stood at the top of the Grand Canyon and you were to shout your name into the Grand Canyon, about a second or two later you would hear an echo. You'd hear the reflection of the sound coming out of your mouth, hitting off the rock and coming back again. And that time delay between making the noise and hearing the echo gives you information about the distance, what's away from you. So this technology was used during World War I. It was a way of detecting submarines. It also exists in nature. It's the way bats see. It's a process called echolocation. There's good reason to believe that bats do build a genuine visual image using sound instead of light. And it's also the trick that you get taught in school, where you see the lightning and hear the thunder later, and you do a little quick calculation to find out how far away that event is taking place. So when we do this with the heart, we get these beautiful images. Unfortunately, I can't show you the video images, and these are still images, but what we actually see when we do this kind of scan is real-time video footage of your heart operating. So we can look at those two key principles, those two important components of the function of the heart. We can look at how it squeezes, and we can look at how it relaxes. If there is any issue with those things, what we're interested in is whether or not a patient has symptoms from them. And the symptoms are pretty easy to understand. You can imagine that if the heart's failing, if it's not able to keep the blood moving forward as well, well, then you get a backup of pressure. And that backup of pressure occurs inside the lungs. And as a result of that, people experience breathlessness. But similarly, if you're not keeping the blood going around the body as well, then you're not nourishing all of the body tissues, and so you're left feeling tired, sleepy, low energy, and these are the key symptoms of heart failure. People experience breathlessness and fatigue. In addition, the heart has to push fluid to the kidneys, and you all know that the kidneys have an important job to make urine, to remove fluid from the body. And if the heart can't get the fluid to the kidneys as well, the fluid builds up inside the body, and so you end up having fluid retention, and because of gravity that would tend to head down towards the ankles. So these would be the very typical symptoms of the heart failure syndrome: breathlessness, fatigue, and evidence of fluid retention. Again, we can do an awful lot to treat this condition in this day and age, and it would be true to say that we've greater options for treating the form of heart failure that exists because of difficulty with squeezing than with relaxing. And as Professor McDonald was talking about, this unit is very keenly engaged in research to look for new novel therapies that can help with the form of heart failure that comes about because of poor relaxation. So the other thing we can do as well as look inside the heart, and Professor McDonald explained this to you, is we can do a simple blood test that we call BMP. There's some variations on it, but for the sake of simplicity we'll call it BMP. And this is a wonderful blood test, not only to help us diagnose heart failure when we suspect it in people, but more importantly, it's a really good blood test that lets us get a sense of the risk that a person has of developing heart failure if they have some risk factors for that to take place. So again, people who have hypertension, so that's high blood pressure, and diabetes, a modestly raised BMP, the simple blood test, would suggest to us that the heart failure syndrome is emerging. Doesn't mean a person has it. And that's really important information for us to know, because as I'm now going to explain, there are things we can do to try and slow the progress and even hopefully stop the development of heart failure. So I'll talk a little bit about that now, how we can go about preventing it. Many of the prevention strategies are the things I'm sure all of you know. They're lifestyle changes, and the lifestyle changes that make a difference to reducing your risk of developing heart failure don't just reduce your risk of developing heart failure, they reduce your risk of heart disease in general and many other diseases. These are really important things, and I'm sure all of you know them, everybody does now, but it's worth going over them again. So the first one I'll talk about is exercise. In reality, I'm always dubious about quoting too many numbers of people, because if people do more than the numbers, there's a tendency to cut back. If people don't do as much as the numbers, they tend to give up. But look, for what it's worth, we like to see people do at least 150 minutes of brisk walking per week. And you can break that down in several ways. That might be just over 20 minutes a day every day, or it might be 30 minutes a day for 5 days of the week. But clearly, I'm sure you know this without me having to tell you, the more you can do, the better. There's always going to be people who find it difficult to even do, say, 20 to 30 minutes of exercise per day, and there's very legitimate reasons for this. People can have issues with their hip joints, they can have back pain or arthritis, but nonetheless, any amount of exercise you can do substantially decreases the risk of the development of heart failure by various mechanisms, not just a direct effect of exercise, but exercise tends to improve other risk factors, things like high blood pressure and high cholesterol. The next thing I want to talk about is diet. Diet is always a complicated one, but a well-balanced diet is very important. And generally, we like to see about a third of your intake coming from what we would call starchy carbohydrates, potatoes, rice, pasta, and that sort of thing. The good old-fashioned advice, which is still true today, is try and get 5 portions of fruit and vegetables every day. The other important thing, and you all know this, is to try and cut down on the sugary foods. So these are the sugars in fizzy drinks, alcoholic drinks, the sugary breakfast cereals and this sort of thing. And also try and reduce saturated fats. So they're the fats that you will find in things like hard cheeses, cakes and biscuits, sausages, cream and butter as well. And very importantly, reducing salt intake has a significant impact on your development of heart disease, primarily because it helps to reduce your blood pressure. Alcohol is always a tricky one. I guess when people come to see us, what they really want to hear from us is you can drink alcohol and all will be well. It's not possible to do that. I often make the analogy with crossing a road. Clearly, if you try to cross a motorway blindfolded, you're asking for trouble. But if you try to cross a road at a pedestrian crossing, the green man's showing, you look left and right, and the cars have come to a stop, actually it's pretty low risk. You can't say that it will be fine, but it's pretty low risk. And this is the way we approach alcohol. If we were having this chat a few years ago, we'd be telling you that if you're a man, you can have up to 21 units per week, and if you're a woman, you could have 14 units per week. Things have changed, and actually things have changed in a curious way, because different countries now have different guidelines. The ones I put up here, purely because it's visually attractive, it's a nice slide, actually come from the UK. So the HSE guidelines in Ireland say that it's 11 units max per week for a woman and 17 units for a man. It's a very curious thing, because if you were to hop on the train at Connolly and go up to Belfast for the day, actually women would be allowed 3 units more at 14, and men would get 3 units fewer at 14. So in the UK it's 14 and 14. The guidelines in Ireland are 11 units for a woman and 17 for a man. I think the key point is, don't obsess about the numbers. It's to keep it in moderation. Keep it as low as you possibly can. And I think importantly, never take these limits as a challenge. So if you're drinking 6 units a week, don't say, oh look, I can have more. Keep it in moderation. But it is true that many people, including people with established heart disease, go on to lead long, healthy lives enjoying alcohol. It's just important to keep it in moderation and to try and spread it out over the course of a week, and ideally try and have 2, if not 3 days per week without any alcohol intake. Just to remind you, when I talk about units, you probably remember this sort of thing, but half a pint of normal strength beer would be 1 unit, a small glass of wine would be 1 unit, and a small glass of wine is quite a small glass of wine if you consider that a bottle has 10 units, so these aren't the generous kind that you get at Christmas dinner. A small shot, a small measure of whiskey, that sort of thing, of a spirit would also be 1 unit, and again, that's probably smaller than many people would tend to pour at home. But it's very important to keep it in moderation. It's not an absolute no-no, but it is important just to be sensible about the relationship you have with alcohol. The next, change that slide, sorry. Smoking. This is one which is non-negotiable. Smoking, absolutely not. It is a catastrophic thing, and if you do smoke, by far one of the best things you could ever do for your health is to quit smoking. There is no negotiation when it comes to smoking. This website that I put on the slide here, www.quit.ie, is an outstanding resource. It's plenty of advice, hotline number. It's a fantastic thing for those of you who are struggling to quit. And your pharmacist and your GP are great resources as well. I can give you fantastic advice on strategies to help you get off cigarettes, advice about the use of nicotine replacement therapy. But this is not, unfortunately, something that we can negotiate. It is always bad to smoke cigarettes. So they're the sort of lifestyle things. I'm going to talk now about a few of the medical conditions that also increase your risk of heart failure. So high blood pressure is one. High blood pressure is interesting because most people who develop high blood pressure don't know they have it. So unless you're actively getting screened by perhaps popping to your GP once every 12 months, or have a monitor at home, or attending the service that we offer in STOPHF, you may not even know you have it. It is very important because high blood pressure doesn't just increase your risk of heart failure, it increases your risk of many other cardiac conditions such as heart attack. It also increases your risk of stroke, kidney damage to the back of the eyes, and it's a very treatable thing. It's a very, very treatable thing. For those of you who are interested, we generally like the blood pressure to be less than 140 on 90. So many of you may be familiar with the idea that blood pressure has an upper reading and a lower reading. We like that upper reading less than 140 and the lower less than 90. In addition to high blood pressure, we've diabetes. This is something that we don't necessarily actively get involved in our prevention service, because diabetes is something that needs to be managed by a discrete specialist team. But for those of you who do have diabetes, take it seriously, follow the advice you're given, and make sure that you're getting regular attention for it, either by being managed by your GP or a specialist service in a hospital. Finally then, I just want to talk a little bit about high cholesterol. Cholesterol's gotten a little bit complicated. There was a time where we kind of thought it was causing all manner of problems. It certainly does cause problems, but we have to be careful about overemphasizing it. In an otherwise healthy person with no other risk factors, a cholesterol up to say 5 would be reasonable. But in the presence of other issues, we prefer it to be a bit lower than that, a bit lower than 4. I don't want to say too much about the numbers, because again, I'm not a fan of obsessing about numbers. Things need to be interpreted on a case-by-case basis. But certainly, one important thing to know is that even with the best will in the world, with regular exercise, eating oily fish, keeping your weight under control, all of those things that can help your cholesterol, unfortunately about 70% of the cholesterol in our body is made by the liver, and there are many people who will have high cholesterol despite best efforts, and that's where medication often comes in. But those sorts of things, keeping the lifestyle factors in check, and that's something you can do yourselves, and we will help you with that. And then also keeping these other medical risk factors in check. These will reduce your risk of the future development of heart failure and many other medical conditions. So in summary then, this is a preventable condition by and large. If you are to develop it, it's a treatable condition, and it's been an absolute pleasure talking to you this evening. This is, I want to say thank you, because this is our first experience having a meeting like this in what we might call a virtual sense, as we said, of our first webinar, and it is a great pleasure, and I'm very honoured that I was asked to speak to you this evening, and I look forward to seeing many of you again in the future, as I'm sure many of you watching I have met in the past.